Hello and welcome. I am Christina Denic Roberts. Before we get started with the session, I wanted to share a couple of housekeeping slides first. First, closed captions are available throughout the day. To turn captions, click the CC icon in the top right of your screen and choose your preferred language. If you run into any technical issues or need an accommodation, please email allofuscienceday@pyxispartners.co. Next slide. To ask a question, please select the Q&A option at the top right of your screen, type your question, and click Send. Questions submitted through the chat box will not be monitored. The chat is public, so please be mindful of any personal information that you share. And now we'll move into our poster presentations. In this session, all presenters will focus on seeing the whole picture of health. I am delighted to introduce our panelists today. Please join me in welcoming Dr. Shanshan Song, a postdoctoral research fellow at Johns Hopkins University, Krista Ochoa, a data analyst at Baylor Scott and White Research Institute, Nick Solini, a graduate student trainee at the University of Arizona, Margaret Rencher, a graduate student trainee at the National Human Genome Research Institute at the NIH, Dr. Jonathan Moore, an early career professor at the University of North Florida, and Tanguy Ruba Dumorak, a pre-doctoral graduate student at Vanderbilt University. During this session, our first three speakers will present, and then we will have a first Q&A session before our final three speakers present. We will then wrap up with the second Q&A for the final three presenters. We will begin today with Dr. Shanshan Song's presentation. Go ahead, Shanshan.
Hello, everyone. Good afternoon. My name is Shanshan Song, and I'm a researcher from Johns Hopkins University. Today I will present our work entitled Characterizing Non-Sharing of Provisioned Wearable Data in the OFAS Research Program. So wearable devices offer important opportunities for large-scale health research, but disparities in the access and the use can limit data representativeness. So while providing the devices through a provisioned model is often used to reduce this gap, participants may still not share their data constantly, creating a potential gap between intention and actual data contribution. So our primary aim was to identify the factors associated with non-sharing of wearable data when devices are provided. And our secondary aim focused on a subgroup of participants with prior being your own device experience, or BYOD, to examine whether attributes of their personal devices were associated with non-sharing behavior. So this is a retrospective observational study using data from the OFAS wearable study. So participants were adults enrolled in the program who were provided with a Fitbit device, specifically the Charge 4 and the Versa 3 models. So provisioned device use was defined from the first activation date after the consent. Our outcome was non-sharing, defined as failure to share step data for at least 1 day after device provision. We used descriptive analysis and the multivariable logistic regression models to examine the associations. So for the primary analysis, we included social demographic factors and the prior BYOD experience. For the secondary analysis, we examined social demographics and the personal device attributes among those with prior BYOD use. So in our cohort, we identified 4,958 non-sharers and 26,126 data sharers. So non-sharers were more likely to be female at 70% compared to 64 among sharers. A slightly higher portion of non-sharers had income below $75K. Prior BYOD experience was more common among the non-data sharing people at 15% compared to 7% among the people who share their data. So after adjustment for covariance in the full cohort, women had higher odds of non-sharing compared to men. Black and Hispanic Latino participants also had significantly higher odds of non-sharing compared to white participants. Participants with income above $50K had higher odds of non-sharing compared to those with income below 10K. And prior BYOD experience was associated with 1.65 times higher odds of non-sharing. In the BYOD subgroup of 1,726 participants, those whose provision device matched their prior personal device model had significantly lowered the odds of non-sharing. So in conclusion, providing the Fitbit devices did not guarantee complete data return. About 17% of the participants did not share any step data, with lower sharing observed among women, Black and Hispanic Latin participants, higher income groups, and those with prior being your own device experience. However, familiarity with the exact device model appeared to improve the sharing behavior. So future work should incorporate additional determinants such as health literacy and digital literacy and the geographical variations. We also aim to better categorizing missingness by distinguish between the technical issues, the non-wear and intentional non-sharing using device level logs or follow-up assessments. Finally, linking barriers to targeted evidence-based interventions may help improve data completeness in wearable-based research. Thank you to the OFAS research program for providing the data and the opportunity to present our work. I welcome your questions and the feedback. Thank you.
Thank you, Dr. Song. Up next, we have Krista Ochoa.
Hi, everybody. Thank you for having me. My name is Krista Ochoa. I'm a research data manager analyst at Baylor Scott & White Research Institute in Dallas, Texas. And I'm so excited here today to present our project, the Association of Disability Status with Social Engagement and Physical Activity, Insights from the NIH All of Us Study. So in my work here at Baylor Scott & White Research Institute, we have a lot of projects centered around people with disabilities, particularly those with brain or spinal cord injury or stroke. So when we got access to the All of Us Researcher Workbench, we were really eager to start leveraging this data to understand a population that's often underrepresented in research for a variety of reasons. So just as an introduction for this specific project, disability is reported by about 1 in 4 people in the US, according to some recent estimates, with cognition and mobility being the most reported types. And research also shows that people with a disability are more likely to be socially isolated and participate less in physical activities than people without disabilities. And a really big gap in disability research as well is that our national level research often lacks sufficient diversity and sample size to examine these disparities across different groups in detail. So what we did with the power of the All of Us workbench is, well, first off, the goal was to examine the prevalence of different disabilities by type, and then to evaluate how having any disability was associated with satisfaction in social participation and physical activity. So so we started with anybody who did the basic survey, and we used these 6 questions here. Apologies if it's a little bit small, to classify whether anybody had a disability. So just yes, no, and we used chi-square and Kramer's V to assess significance and effect sizes. So once we did that, we had about 175,600 participants, and about a fifth of them reported having at least one disability, with the most common being with walking or climbing, and with difficulty concentrating. So that does align well with the current previous research. And compared to those without disabilities, they notably had a lower satisfaction with social activities, and that's represented in the graph on the right-hand side. So people, you can see with disability, have a lot more of that like yellow, orange, and red compared to those without disabilities across all 3 domains. So significantly less satisfaction with social activities, carrying out physical activities, or carrying out social roles. And the effect sizes ranged from 0.19 to 0.30. So we can see that having a disability was a moderate effect size on all of these questions and domains. And then on the left-hand side, there's a graph showing the prevalence of different types of disability in the sample. So least common being vision and self-care. So those were the key findings. And really, this just is like barely scratching the surface, I think, of what's possible with the All of Us program data. So it was very encouraging that our findings were consistent with previous research. We hope to really drive this further by utilizing all of the different data sets that are available within All of Us. There's such a powerful resource that we can use for identifying accessibility barriers, informing interventions. We can combine it with the power of the EHR and different surveys covering lifestyle, socioeconomic factors, the wearable data that we just heard about. It's my hope this is going to be a really powerful, low-cost resource that's going to inform future research, policy, community-based efforts to improve accessibility and inclusion. And it's going to be a great resource for studying an underrepresented population. And so I guess stay tuned for our continuation of this work. And I didn't even have a chance to get into the demographic differences and some other really interesting insights that we can gain from this research. So yeah, thank you so much. And I look forward to answering any questions. Thank you.
Thank you so much, Krista. Next up, we have Nick Solini. Take it away, Nick.
Hi, everyone. So my name is Nick Solini, and I'm going to be talking about characterizing Alzheimer's disease and related dementias in All of Us. So obviously, there's a lot of information on this poster. I'm not going to be able to cover everything, but I am going to hit some of the highlights here over the next couple slides. So first off, real quick, why Alzheimer's disease, right? So Alzheimer's disease-related deaths, they have increased by 142% from 2000 to 2022. So it is a rather significant public health burden, and the literature does show it disproportionately affects both women and Black or African Americans. So in the All of Us data set, when we filtered for those who have ADRD, which is Alzheimer's disease or related diagnoses, and they're in their EHR or in the self-reported survey history, we actually found just under 9,300 participants. Of those, 56% were women, 61% were white, and 80% were non-Hispanic or Latino. So that does align with the literature in terms of the gender distribution, but for the race distribution, that actually does not quite align with what we fully expected. So from there, we wanted to then understand, what are the health factors that are driving these disparities and this burden of ADRD? And then can we use that? Can we look at the data and figure out ways to target intervention approaches to hopefully support downstream healthy aging? So one of the health factors that we looked at, a number of them were social determinants of health. One of those in particular was neighborhood deprivation index. And so for neighborhood deprivation index, that's what we're seeing in this heat map down at the bottom. There's a couple things here that are kind of interesting, but the big one here is this white demographic, where we can see has an 82.3% representation in quartile 1. That's the lowest level of neighborhood deprivation, and it decreases, their representation decreases as the disparity, the neighborhood deprivation, increases. But we see the exact opposite for the Black demographic and the Hispanic or Latino demographic. So there's a couple things this could be suggesting, but what we kind of realized by looking at some of the other social determinants of health that we saw is that those groups, those demographics that had the most data available, the most data completeness, tended to have the lowest amounts of disparity. I'm not going to come back to that here in just a bit, but real quick, I do want to take a moment and step back. Yeah, there we go. So real quick, kind of what exactly did we do for this study? So the first thing we did was we developed a reproducible phenotype in order to define that ADRD cohort. From there, we then ran a number of baseline descriptive statistics, basically just kind of asking, who is getting this disease? And then of those that are presenting with this, what is the distribution of those concepts, right? Those types of diagnoses. From there, we then wanted to assess and identify, are there any structural data gaps or disparities in that data completeness or data availability between these different demographics? And so what we kind of found overall is that the white and the non-Hispanic or Latino demographics are significantly overrepresented in terms of that data availability and completeness compared to all other races and ethnicities. And this holds not only in that overall, do they have that history of ADRD, but as we started, adding additional filter steps, are asking, do they have multiple visits? Do they have socioeconomic data? Do they have genomic data? At each one of those filtering steps, we actually saw this representation increasing, right? So it does kind of show that those two groups in particular are just significantly overrepresented at all steps of this. And it does kind of tie into what we saw with that socioeconomic or that neighborhood deprivation index, and that those groups that had the most amount of data availability tended to have the lowest amounts of disparity across a number of different social determinants of health. And so this does kind of represent a bit of a methodological risk in that if we are not targeting the populations that are shown in various other literature to have this significant burden, we might not actually be identifying the true factors we need to. Which kind of leads us into, how do we take this and translate it into future efforts, and ultimately, how do we hopefully improve healthy aging, right? So the big thing here is that we are developing that reproducible framework to create that cohort, and that should hopefully help future research efforts. They don't have that initial burden, and they can focus more on determining the actual causal effects driving these disparities and these diagnoses. And then hopefully this also helps allow us to target interventions specifically on those demographics that are lacking representation. For instance, if we see we're not collecting enough data on that Black or African American group, now we can kind of go back and reassess, well, how are we recruiting them, and can we focus our efforts a little bit more on this demographic? Thank you.
Thank you, Nick, and thank you all. Now we will bring our speakers back on stage for the first Q&A session. If you have any questions, please send them through the Q&A box. Okay, I have a first question for Nick here. So what would be the take-home message if there were other health outcomes or inflammatory diseases related to this finding? Healthy aging research should take those into consideration.
Yes, that's a good question. There's certainly a lot of comorbidities that are going to play a role in healthy aging. In terms of just Alzheimer's and dementia, for this particular stage of our research, it's a bit outside of our scope. However, we do recognize that a lot of research is going to need to be done on those comorbidities. We do have another paper that's currently, we're currently in the manuscript stage that's looking at the impact of depression as kind of like a mediator role in terms of like inflammation and how that affects it. And that does have a pretty significant effect as well. In terms of, a fully healthy aging, yes, we are going to have to take into account a lot of different comorbidities. But until we can do that, we need to, characterize the data, right? We need to know what's actually in there before we can start pulling in different comorbidities.
Thank you. Okay, so I have a question for both Krista and Dr. Song. Nick, you've kind of talked about this in your presentation, but Dr. Song and Krista, could you talk a little bit more about the potential impact of your research?
Yeah, I can go first. Yeah, thanks for the question. So the potential impact of the research is that, so we have noticed like certain subpopulations may have like a higher chance to not share their data. So I think for us, our next step, as we have indicated on the slide, is that we wanted to understand why they have not shared the data. So currently the office itself haven't provided such a kind of information. I think it would be great if we could have such kind of information. And for the researchers who are going to use this data, I think we should just as researchers, other presenters have mentioned, we should just remember that the data missingness and the bias would impact our model outcomes. So I think whenever they are going to use our wearable data, I think they should keep in mind. Thank you.
Yeah, that's a really good question. And this is very preliminary, and I'm really excited to bring this research further and really applying it to finding interventions for different subgroups of people with disability. As we saw, there are different domains And so I think our next steps would be kind of breaking those out, bringing people out by disability, looking at things like healthcare utilization, and understanding like what might be the barriers for different groups in healthcare utilization, and what might facilitate people getting access to medical care, and really just hopefully informing some kind of clinical trial or intervention to improve quality of life for people with different disabilities.
Thank you, Krista. So we have a question from the audience. Did any of you try to access details from medical records? If so, what types of information were you able to obtain and not obtain?
I have not looked at medical record data for this project. I know for a separate project looking at brain injury, we were able to get like diagnosis, like date and time, very kind of high level EHR data from what I saw, but nothing related to this project.
Yeah, for ours, we pulled diagnostic history, visit types, visit dates, number of visits. We also pulled all sorts of demographic information, race, gender, things like that. We also pulled a number of like biomarkers, things like blood pressure, weight, BMI, things like that. So yeah, a lot of our data was pulled from EHR from medical records.
Yeah, the same here for our study. So we have used the conditions and survey responses to identify the conditions that people have. I know we have worked on some other projects using Office data as well, and they have, because this kind of a map to the OMAP data model. So basically, like whatever the OMAP data model has, we have including their medications and their like also like I noticed that we have quite a good amount of social determinants of data as well. So I think that provides a lot of opportunity for our researchers to just like work on our research questions.
Thank you. We have about a minute left, so let me ask this question. Can you talk about some of the challenges you had working with wearable data using All of Us platform?
I will just go first, just in case other people might just like follow up with me. So while I was working on the wearable data, I think one challenge that I have noticed is that it's a little bit challenging to distinguish the device that people have used. So sometimes like one participant may have like multiple devices like linked to their profiles. But I noticed that we already have researchers publish the guideline tutorial about like how to better use the research like wearable data from the office. So I would definitely recommend you to just check that literature.
Thank you so much. Thank you all for your presentations, and thank you to the audience for participating in our first Q&A. Now we're going to move on to our last three presentations, and to start, we have Margaret Rancher.
Okay, hi everyone. My name is Margaret, and I'm super excited to share about our project combining health record and survey data improves genotype and phenotype association replication in All of Us. So to start, large biobanks like All of Us present this huge wealth of data to us that is changing the way that we can study biomedical research and gene disease relationships particularly. Previous research has often used these health records or EHRs to identify which participants have a particular disease. However, although it sounds super intuitive, consistently and accurately identifying disease presence remains really challenging for researchers. So even though EHRs provide this huge amount of information, extracting something meaningful can be complex, nuanced, and often really difficult. Participant surveys like those collected by All of Us about personal health information present another approach for identifying disease presence within a cohort. However, not many studies exist currently that directly compare health record and survey-based approaches to identifying gene disease relationships. And the utility of combining these two data types remains understudied in scientific literature. So what we're aiming to do here is to systematically compare the performance of health record data and survey ascertained cohorts, and replicating both known genetic associations and identifying previously unreported signals within all of us cohorts. So what we did first is we identified all 152 unique medical conditions in the All of Us Personal and Family Health History Survey, and we were able to map 129 of these to fee codes. Fee codes are an aggregate of medical billing codes that represent something clinically meaningful or a medically relevant illness or condition. So by doing this systematically, we were able to compare survey data to health record data in a fair way. And those survey conditions that we weren't able to find an appropriate health record code for, we just threw out of our study. So after that, we took gene disease associations from the phenotype genotype reference map, which is an aggregate of gene disease relationships that have already been identified by previous biomedical research studies. So our first thing to do is to see how well EHR data and survey data perform in replicating these genetic associations that we already know exist. So we compared 4 case definitions, fee codes or EHR data alone, survey data alone, fee codes or survey, and then fee codes and survey, so the intersection. As you can see in figure 3, although we found that fee codes and survey, the intersection reproduces known genetic associations at the highest rate. Using fee codes or survey, or the union, provides us the statistical power to replicate the highest number of genetic associations. So knowing that, we wanted to see how survey and EHR data compare in identifying novel genetic associations, or how can this be used in practical research to identify something clinically meaningful. So we chose six medical conditions to perform a genome-wide association study on. And as you can see in figure 4, we found that in all 6 conditions that we chose, using fee codes or survey together, the union almost always identifies the highest number of novel genetic loci. So how can we use this to inform future gene disease research, especially using cohorts from all of us? We can see here that combining personal health survey and EHR data has a lot of potential to enhance genetic discovery that is conducting using these super rapidly growing EHR-linked biobanks. So ultimately, we hope that this work gives researchers a more complete view of EHR and survey data within our cohorts and allows them to make informed choices when identifying disease presence as this data continues to grow. So thank you all so much for your time. Very thankful to be able to share this research with all of you and happy to answer any questions.
Thank you, Margaret. Up next, we have Dr. Moore.
Hello, everyone. It's a pleasure to be here. My name is Jonathan Moore. I'm a recent assistant professor at the University of North Florida and happy to present my research using All of Us. I've used All of Us data for the last couple of years at my postdoc I did, and then now at my faculty position. I'm starting to work on it with students, which is great. So the topic of my research is assessment of sedentary behavior in the United States during the pandemic era using the All of Us research program. So I looked at data over the period of time between 2019 and 2022, what we refer to as the pandemic era, using Fitbit data specifically, and we were looking at whether these patterns changed over time, as well as across certain demographic groups. So sedentary behavior, for those who are not familiar, is defined as time spent sitting or inactive or laying down during normal waking hours, so sleep does not count. And it's an important public health concern. Higher levels of sedentary behavior are associated with higher rates of cardiovascular disease, diabetes, and cognitive decline. And this association exists even apart or independent from physical activity. So you could be very physically active, and still, if you have high sedentary activity, you're at higher risk of having these health conditions. So very important to address. The the pandemic, as we all remember, likely altered sedentary trends, and that's what we were looking at in this study. There was stay-at-home orders, and businesses were closed, and people were working from home instead of working outside of the home. And so there were a lot of changes that ended up occurring. And so we need some objective longitudinal data. And because data was not collected from other data sources, it was great that we had data across the pandemic period for all of us, which is very exciting for me and my researchers. So the purpose of this was to examine temporal trends, over time, and then also look at differences between different demographic groups. And the ultimate purpose, of course, is to inform public health interventions to ultimately improve the health of the public as possible. So that was the purpose of our study. Our methods were retrospective longitudinal, and we utilized Fitbit data. So our final sample size ended up being 7,196 people. And this was actually a very large sample size for this type of data. My colleague who worked on his dissertation was very happy to get 30 participants for his study. So this is very almost unprecedented to have this kind of level of Fitbit information. And so the analysis we ended up conducting was a repeated measures ANOVA, and then subgroup analyses. However, we decided to conduct also a sensitivity analysis. I didn't include information here simply because we had to remove individuals that did not have data for all years of the study from 2019 to 2022. So we did a mixed effects model, which incorporated the missingness, and we found that the differences were negligible between models. So we stuck with the repeated measures in the end. So overall, the results of our study were that there was no real significant change from 2019 to 2020. There was a decrease from 2019 to 2021, which we were a little surprised by, and then a subsequent increase in sedentary time between 2021 and 2022. And we also noticed subgroup differences. Females and non-Hispanic individuals had higher sedentary minutes than other groups. So in conclusion, sedentary behavior changed, but not uniformly. Evidence of rebound effect after the pandemic, and future directions would be to also include other data sets that are representative of the U.S. population, in Haines possibly, examine policy and regulation effects, and study long-term health outcomes of this sedentary behavior. Thank you.
Thank you so much, Dr. Moore. And up next, we have our last presentation in this session by Tanguy. Go ahead.
Okay. So hi, everyone, and thank you so much for this opportunity to share some of my research on how the biology of language skills relates to our overall health. So as you may know, speech language disorders are highly prevalent in the United States. And we know that such conditions can have a huge impact on the person's family relationships, sense of belonging, academic achievements, and many aspects of our mental health. Now, it is true that language does not depend only on our environment, but is also shaped by our biology, including our brain and our genetics. So previous studies show that there are several genetic factors that explain differences in our speech and our language skills. And we know that the same biology is also connected to many facets of our health. So in this study, what we wanted to do is look comprehensively at how speech and language skills biologically connect to all different dimensions of our health. So for our first research question, we asked to what extent genetic scores for language skills on the left, based on many, many different genes, predict medical problems across the entire landscape of our health, pictured on the right. And so this is what we call a phenome-wide approach, and means we did not look only at specific health conditions or specific disorders, but instead we looked at every single medical code included in every patient's electronic health records. Now, for our second aim in this study, we decided to zoom out and we looked at our result and tried to identify medical categories that would be overrepresented compared to chance. So overall, what did we find? Well, we found that speech and language skills do appear to be biologically connected to many facets of our health. We combined the results from all of us and the Vanderbilt Biorepository, accumulating a little more than 235,000 participants. And our results showed that genetic scores for more accurate language task performance were associated with a decrease in odds or lower likelihood of substance use, hypertension, and metabolic conditions, including, for example, obesity. And we found association with increased odds or higher likelihood for dermatological conditions and benign neoplasms. So for our aim 2, we next identified 6 medical categories that constituted what we would call the bulk of the association signal. So including mental diagnostics, metabolic, dermatological, gastrointestinal, and cardiovascular and respiratory conditions as well. So as you see from all these results, the genetics of language appear to be associated with both risk, but also protective effects across many aspects of our health. So with that in mind, this project is just the first step towards what we would call a more holistic understanding of language and health connections. We can find or think of what we call a language profile as a combination of one's genetics and brain factors supporting language, developmental trajectories as well. But the long-term vision for this work is to have clinicians and us researchers exploring these different dimensions of the language profile to inform how we develop and implement interventions within the context of language disorders. And that way, we hope to be able to anticipate diagnostics, but also maximize the therapeutic benefits for every patient, thereby hopefully granting a better health for all of us. So with this in mind, thank you all for your attention. I'm really grateful to be here today. And again, for this opportunity to share some snippets of my work. A huge shout out to Dr. Nayak, who has been mentoring me on this project, the whole team involved, all of us and Vanderbilt participants, and our funders as well. And please, happy to answer any question during the Q&A. Thank you so much.
Thank you, Tanguy. Okay, now we're going to bring the last 3 speakers back on stage for the final Q&A portion of today's session. Just a reminder to please send any of your remaining questions through the Q&A box function. Okay, let me see. Okay, so we have a first question for Dr. Moore. So the pandemic led to more sedentary time, but for those with long COVID, including brain fog, I'm reading a lot of different conditions here, PEM, many likely have dramatically dropped their activities. Was this considered for general population versus those with post-COVID conditions like long COVID, ME/SFS?
I think I understand the question. Thank you for posing that. We did more of an overview, an overall study. We didn't look at specifically long COVID and symptoms, but that would be an interesting, very interesting study to do in the future. It seems like we would probably have, because there's so much clinical information in all of us, that we would have data for long COVID, post-COVID. So yeah, that's definitely a potential for the future.
Thank you. Okay, I have a next question here from an audience member. So far, studies discuss that use the All of Us database seem to be predominantly quantitative or even mixed methods. How can the All of Us database also be useful for qualitative researchers? Could you give some examples? And this could be answered by anyone.
The only thing I can think of is just when you have medical record data, and I have a colleague who really got in deep with it, that you can possibly get like doctor's notes and then do some kind of classification into different categories and that kind of thing. That's really all I can think of for qualitative data.
Thank you. And the program is planning to include clinical notes soon. I have another question for Dr. Moore. This is a really great synthesis of the longitudinal data. How can we apply this when considering health outcomes? Should we consider multiple health outcomes? And if so, how should we model this type of problem?
That's a great question. There are a lot of different, so for our study, we didn't have an outcome really. We had just looking at our topic of interest, sedentary minutes over time. You could look at different outcomes, and there's lots of different clinical outcomes in all of us. So that's really ripe for plenty of different research topics. And you're looking at different subgroups, considering there's so much information for these wearables in all of us, these extremely large sample sizes. So I think that you could look at cardiovascular disease, dementia. You could even tease out between vascular dementia and Alzheimer's disease for those who are interested in that area. So it's endless what you could study.
Thank you for your answer. Another question, can you say a bit more about the magnitude of this discordance and the variation? Which measure, ICD or self-report, was more often right if you use the genetics as your gold standard of truth? And I think, Margaret, this one is for you.
Yeah, this is definitely my project. So part of the reason this project caught our interest so quickly is because we noticed there was this huge discordance within all of us between EHR and self-report data. And obviously that is going to bias any studies that are trying to use it to identify disease presence or a gene-disease relationship. So as far as the magnitude, that was really surprising to me when I started this project. And as far as what's often the right, is a really difficult question to answer. And I guess the answer I would give right now is there is no right answer to what is correct. And that's part of why it's so important to understand the biases that come with using these types of data. Because it's so easy to look at this and think, EHR is the ground truth or survey is the ground truth when it's a lot more going on than that.
Thank you, Margaret. With the few seconds we have left, I can ask a question for Tanguy. Do you have any plans to incorporate any other data types in your future analysis?
Yes, thank you for this question. So currently, the idea is that we have tried to integrate medical data on one side, most likely here, or specifically talking about ICD codes, which several speakers have referred to, but integrated with genomic data. So we're using the sequencing data that's available through the Olbus program. In addition to this, because we're also very interested in expanding our reach to other populations that are not necessarily, European ancestry or European genetic ancestry specifically, we were very interested in trying to make sure we can capture the variation that's across different genetic ancestry. So looking maybe at populations of African genetic ancestry. And the Olbus platform is really great for that because it has that data available. We just don't have yet genetic data associations with language that are powerful enough or that represent those other populations enough yet. But the goal would be to combine this with other, it could be other coding systems than ICD codes that are also available in all of us, but that may not be present across biobanks. That's always the limitation sometimes. And maybe use different levels of the biology. So maybe integrate some not only genomic, but transcriptomic information, maybe incorporate some brain data as well. So those are the future directions.
Fantastic. Thank you so much. In the interest of time, we will end the Q&A now. First, I would love to thank all of our speakers today for sharing their work and demonstrating the potential of using Olbus data. And thank you all for joining us and asking great questions today. There will be a short survey following this session. After completing the survey, you'll be automatically redirected to our keynote session coming up And I just want to also remind everyone to vote for the People's Choice Awards. And thank you again, and enjoy the rest of the Science Day sessions.